thank you so much for taking on this panel, because this is actually going to be a challenging one, I think. We have a lot of complicated issues to discuss. And as we had sort of talked about a couple of days ago when preparing for this meeting, we thought we would identify some important issues that we see are want to be takeaways from this meeting. And really what we wanted to do is identify research priorities and have some discussion about research approaches and talk about some of really the thorny issues related to studying some of the post-acute COVID issues, as well as sort of global inclusion for research relating to these topics. So this is going to be tough because I don't think there are straightforward answers, but I really look forward to having all of you contributing on this. Ms. Hannah Davis, she's a researcher and she's actually also an artist. She's a researcher in data analysis and machine learning. And she is also co-founder and team lead of the Patient-Led Research Collaborative that you heard about several times already at this meeting. She's also, as she described so eloquently today, survivor of COVID and someone who's experienced post-COVID symptoms. So really excited to hear her voice today. So there's a couple of things that we wanted to start by talking about. And again, these topics have also been very informed by the discussion over the last 2 days, particularly I think today. So I think that we've heard a lot about both clinical research, clinical reports, and also sort of even basic science research that's being based mostly in the US and Western Europe. And also I think a lot of the clinical research that's presented does tend to include primarily certain upper middle class, predominantly white populations, at least in the US. So I think what we wanted to talk about are what are the gaps and the challenges that we have relating to catalyzing more research and better clinical care for people in low and middle income countries, and also even in the Western developed countries that include underrepresented individuals. Maybe I'll ask Hannah to comment, because I know you have successfully integrated international sites into many of the projects that you've been conducting. So can you kind of tell us about how that's worked and what you see the challenges are?
Absolutely. Yeah, that was a big priority for us. And I would still say, even though we do have a large cohort, it's still not as global as we would like. Although now at this point, we have about 8,000 responses from about 85 countries. And this was doable only because we connected with other long COVID patients in other communities really early, like, we're talking like April, May last year. And I think that we have a lot of patient advocates in countries like the US and the UK, but some of these advocates in countries like Indonesia or South Africa, there's like a couple patients kind of doing this alone. And so one thing we've done at Body Politic and patient-led research is found those patients and tried to support them as much as possible. And they conversely have worked for us doing like translation, so translating the same long COVID surveys into the relevant languages, which really helped get more responses from those populations. So we ended up translating our survey into 9 languages, and then we worked with those kind of existing networks to distribute the survey. And then once you have that data, it becomes much more possible for those patients to reach out to and find, sympathetic doctors who will then kind of go forward with the research. But I think a lot of it is really related to kind of communication, science communication, and networking of existing networks. And I think that's true for the US too. Like one thing we really have to do, which is not being done right now, is prioritize Black and BIPOC patients. And that also is going to be based on, funding and highlighting existing community networks. And really importantly, I think a lot of conclusions have been based on available data, which comes from support groups, comes from long COVID clinics, and is disproportionately white. And we really do need to actively fund community leaders in these spaces to get a better understanding of how this is affecting BIPOC communities, because it's just not going to be the same in those white patients who are able to get into long COVID clinics, who were able to get PCR tests early enough. One major issue of having PCR positive research is that you do get a cohort that is has a better access to healthcare. So this really needs to be an active process. This is not something that we can do passively.
And this relates to how to actually design and implement studies of post-COVID syndromes. So I think what we were just talking about relates to everything across the spectrum, from acute COVID to clinical care to post-COVID. But the post-COVID puzzle is so challenging for all of us, those who have lived through it, that we heard about so eloquently today, and many people who have tried to take care of patients who are having post-COVID neurologic or psychiatric issues, and also study people. And I'd like to think about how do we actually answer some of the really important fundamental questions by designing studies the right way. We heard just now, I think, a number of different studies that have clever study designs, really wonderful data before and after COVID, excellent comparison groups in these very large scale database type studies. But if we were able to design the ideal way, for example, to get critical biological and psychiatric and behavioral information about the biological underpinnings, the natural history, the treatment of post-COVID issues, how do we do that? Who are the comparison groups? How long do we need to study people? Are we going to be able to see effects in 1 or 2 year studies, or do we need 10 or 20 year studies? And maybe, Hannah, if you wouldn't mind starting with that question and saying, sort of from your perspective, from your experience, what do you think?
Sure. Yeah, that is a really complicated question. I think there's a couple of components. Definitely, I do think we are going to need to look at kind of long-term studies. I think 2 years is going to be kind of the baseline, but I think, like a lot of people said today, we don't know the long-term effects. We don't know if this is going to end up in a big wave of, Alzheimer's or dementia, or hopefully not, as someone affected. But I think we need to be looking long-term. We need to be looking at, I think, as many people as possible before restricting it, as I mentioned, by PCR positive and antibody positive. As I mentioned in my talk, there's a couple studies that have come out now that actually show that low or no antibody in the acute phase of COVID actually predicts persistent symptoms, which is, one of kind of the only real answers we have around long COVID. And I really think that despite there being such a high focus on respiratory symptoms, one of the main things we found was that when we looked at all of these 200 symptoms over time, some of them, like the respiratory symptoms, actually decrease pretty rapidly over the first 7 months, where the systemic and the neurological symptoms are significantly more likely to either not change over time or actually increase over time. So I think that we really do need to be focusing on kind of neurologic specific studies, and also funding studies that kind of have been based on the neurologic and neuroimmune work of myalgic encephalomyelitis, which with dysautonomia is one of the most common diagnoses in the long COVID population. And there have been so many neuro studies in ME, especially over the past 5 years or so, that are directly relevant to long COVID, including like brain and brainstem inflammation, what are the appropriate neuroimaging techniques, hypoperfusion and cerebral blood flow findings, elevated blood lactate in the brain, like overlaps with connective tissue disorders, craniocervical obstructions, all of these things that these ME experts just know like the back of their hand, right? Like, and that these are all areas that are just not well known to long COVID researchers. So one thing I really want to see is, researchers in ME kind of know a lot of these answers that to us look really foggy and unsure. And if I could change, I think one thing about how long COVID research is being done, it's to include ME biomedical experts in these research processes.
So that's a really interesting observation. And, I can say that from myself and for many others, Dr. Knopf, Dr. Gislin, et cetera, we're coming from a perspective of studying viruses in the brain, and haven't actually had, at least in my experience, Dr. Knopf has, but I haven't had a lot of experience with ME CFS. And I think you're absolutely right that there's sort of different approaches to thinking about questions, biological questions, etiologies, presentations and things like that, and actually integrating across those disciplines, which should have a lot of overlap naturally, but I think historically they haven't, is probably something extremely valuable. And I appreciate your point, and in fact, your long email yesterday to me, educating me about some of these issues, which I really am not that knowledgeable about. And it's an omission, I think. And I think as Hannah has raised, that there are these overlaps with other syndromes that have been plaguing patients for many years who have not had answers for the biological causes. And so I think in that sense, this is actually a really exciting time, because of course, if there is a lot of interest and focus and investigation in this area, it could potentially provide insight into some other conditions that are so important. But going back to the question of, should we be comparing people who have had, there's been a lot of discussion in the Q&A, as well as a little bit of discussion here in the group about, do we only select people who've had proven COVID by PCR testing, which excludes a large number of people, including people who didn't have access to PCR testing because tests weren't available, tests still aren't available. Many places in the UK, people, if they didn't have to be hospitalized, they were told to stay home. They didn't get testing, for example. Or do we take people based on clinical syndromes? And, again, as a neurologist seeing these patients, I find that really complicated, because I have a lot of patients I've been taking care of patients with HIV for many years who have some subtle symptoms. And I think that it's really difficult sometimes to say, well, is this related to their HIV or not? And in this era of the pandemic, there have been so many other things happening with patients that they come in and they had some symptoms. They don't have a positive PCR test. They don't know if they were antibody positive or they were not antibody positive. For me, it's very, very hard to categorize those patients, but I absolutely understand the voices of those who feel so frustrated by those kinds of criteria. And we've had to exclude patients from our studies who are really, really disappointed not to be involved. So I'd be interested to hear what others think about how do we decide who to be including in these studies.
I think unlike HIV and AIDS, there's just a much shorter time frame between acute COVID and this long COVID syndrome. And that really makes the difference. And I think it's really hard to communicate as a patient that this is just not like anything I've ever experienced before. One of the things we found is that patients experience literally dozens of symptoms basically overnight. It doesn't make any sense to attribute it to just lockdown. A lot of patients got sick before lockdown, especially from the first wave. And it's a recognizable condition. And I think especially once providers start working with long COVID patients, you can tell, you can understand, the dysautonomia, the brain fog, any breathing issues, you can recognize them pretty easily. And there have also been several studies validating that there are not symptomatic differences between these populations that I think needs to be listened to. And my concern is that we might be wasting time just kind of debating this, where I know this was like a thing in other illnesses where there's kind of a gap between your virus onset and your symptoms, but that's really not what we're seeing here. I mean, we saw less than 4% of patients even had a gap in symptoms. And when they do, it's within a month they're symptomatic again. And so I think kind of we need to base our decisions on that.